An important topic. I want to discuss abuse, particularly abuse of medications. We face this every day in clinical practice. We're prescribing, particularly for ADHD, controlled substances so often. How do we know what our patients are actually doing with the controlled substances we prescribe? The goal of this segment is to look at the potential risks with prescribing ADHD medications and how do we minimize those risks and maximize outcomes for our patients. Dr. Goodman.
Yes? You want me to make a comment about this? Well, let's clarify some terms first before we start our discussion, and that is misuse, abuse, and diversion. Abuse is what we are most concerned about. That's the use of these medications for the purpose of getting high. You need to get them into your system either intranasally or intravenously.
You can get high on these medications.
You can get high. That's why they're controlled drugs. But you have to introduce them rapidly into the serum so that they get into your brain rapidly. Most of the non-prescription use of these medications occurs with misuse. That is the use of the medication for performance enhancement. Typically in college it's for studying. And then you have diversion. That is the diversion of these medications to patients, to people who were not prescribed these, and so you have to be aware of that as well. If
I'm hearing you correctly, the greatest risk then is people giving their medications to somebody who might not need them, shouldn't have them.
Well, and that happens. In surveys looking at high school students and college students, that diversion, that is people who have ADHD known to have stimulant medications, are approached 25% of the time, which is why it's important to tell our patients, if you're on these medications, not only should you not sell them because it's a crime, but even giving them away is a crime.
So let's assist our colleagues, particularly the primary care population that might not have as much time to spend with the patients. And here in the primary care setting, they've got 10, 15 minutes. I feel with a luxury in a mental health practice that we usually get 20 to 30 minutes with our patients. So in the primary care setting, what is the physician going to do to minimize their risk of somebody abusing that stimulant prescription?
If I could say a few words, I think the advent of newer once-a-day delivery compounds has reduced the abuse potential to a degree. We used to have Ritalin and D-amphetamine available in a tablet that was easily crushed and then moved to either intranasal or intravenous use. The newer technologies either use a beaded system, use a micro-drilled capsule system, and the newest technology uses a prodrug system. Vyvanse or lisdexamfetamine is a prodrug that is essentially inactive. So that has been a helpful adjunct to our source of medications for ADHD.
And in a number of studies, the likability of these longer-acting agents, both for the orismethylphenidate and for the prodrug technology, is demonstrated that in equivalent doses of short-acting stimulant medications, the likability of the long-actings is much less, significantly less, and so that they're less likely to be abused because, again, you can't get it into your system fast enough to get a euphorogenic effect.
So what would you like to tell our listeners, Dr. Goodman, about how to minimize their risk day-to-day in their practice?
Well, Harold Schupner at Wayne State actually came up with a very useful clinical tool, and that is to rate the patient based on a risk, a low, moderate, and high risk. Low risk is no history of substance or alcohol abuse and no family history. Moderate risk is recreational use plus minus family psychiatric history for alcohol and substance abuse. And high risk would be active abuse with a family psychiatric history. And if you grade your patients low, medium, and high, then you can have a better idea of the selection of medications. We spend a lot of time talking about once-a-day long-acting stimulants, but there are also non-stimulant medications that can be used in patients that you suspect have a substance abuse problem.
So you're screening the history. And Dr. Cohen, you're talking about also how to use longer-acting medications that may be less abusable forms. So the combination of those two, very helpful tips for our listeners. Dr. Manos, anything you'd like to add to that?
Sure. I'd also recommend that, especially with college students, where diversion is greatest, you say to them, don't tell anybody you're taking this medication. And keep it in a secret place. Don't let people know you have it. Don't let people know they can find it. Because Dr. Goodman is absolutely right. People will want to buy it, they'll want to borrow it, they'll want to take it.
And in doing so, I tell my patients, my college students, that if you come up short, I may not give you another prescription until your due date. So every single pill I give you is for you. If you give it away, That's one less day that you're going to have your medicine available to you.
And one other point is that the long-acting delivery systems tend to be less abusable. That is, you can't crush them and snort them. You can't inject them.
And what are some examples of those medications?
Well, for example, Adderall XR, if you crush it and try to snort it, it just burns the nose. Vyvanse, lisdexamfetamine dimesylate, is a prodrug, as Lee was saying, where in preclinical models, you could inject rats with huge amounts of it, and the rats still wouldn't die. So its abusability is not as, well, it's very difficult for it to be abused.
My understanding is snorting it won't activate it.
No.
Injecting it wouldn't activate it.
And Daytrana.
This is for the Vyvanse.
Yes, and the methylphenidate transdermal patch is also not immune, but it certainly is not as available to abuse as other delivery systems might be, as immediate release medications can be.
So again, for our listeners, longer acting formulations can be helpful, potentially less abuse potential with the longer acting formulations. Dr. Cohen?
There is one thing to keep in mind. There are high-risk populations, so there are a number of individuals that have substance abuse or dependence problems. But interestingly, there has been significant data to suggest that many of those individuals also have ADHD. So sometimes we can treat the ADHD, and that may actually decrease their need to abuse other compounds.
Very good point. A lot of data behind that. You know, a lot of physicians are very concerned about giving controlled substances to somebody that has an abuse problem to begin with, alcohol, drug, and you're absolutely right. The data points to in treating those individuals, we actually can lower and prevent recurrent substance abuse.
Can I ask a question? Would you prescribe a stimulant medication to someone who is, for example, a cocaine abuser right away? Would you wait a period of time? What is the coaching we can offer our physicians?
Interesting topic.
I would not prescribe a long-acting stimulant or stimulants at all for somebody who's acutely abusing cocaine. Francis Levin in New York has done a lot of research. There's now about 16 studies looking at substance abuse and ADHD and the treatment. Most of those are in cocaine abusers and ADHD. The findings are that if you treat the ADHD symptoms get a little bit better. The cocaine abuse doesn't change at all. So this idea that the cocaine is a self-medication, and if I treat the ADHD, the cocaine abuse will decrease, is not supported by the research.
What about these stories of using a stimulant to cut the craving of cocaine?
Well, Dr. Levin has done this, but it's research-based. I'm not sure that the benefits of doing that merit the medical legal aspects and safety of the patient. And so at this point, there's no guidelines for that.
So now let's take it a step further. You have someone you suspect is abusing a medication that you're prescribing. How do you deal with it? What do you do?
I think some people will go to non-stimulant compounds at that point. Based on some of the data that Dr. Goodman is pointing towards, some of those patients just will not be able to tolerate or will not be able to properly use a stimulant compound. So there are a number of other alternate medications that are either non-stimulants like atomoxetine or alpha-agonistic compounds like guanfacine or clonidine that can be used as adjunctive compounds or standalone compounds for the treatment of ADHD.
One of the aspects of this is to try to avoid using short-acting stimulant medications in prescriptions. And in the adult population, in contrast to the child population, where the prescription data is clear that there's been a substitution of short-acting for long-acting, in the adult population, there are still a lot of physicians who are prescribing short-actings so that the patient can take it when they feel they need to. And that has slowly increased to about 46% of stimulant medications are now short-acting for adults. And so it's curious. We sit here trying to advocate long-acting for the obvious reasons we've discussed, and yet the increase in short-acting is still problematic in the adult population.
So thinking preventively for our primary care audience, what we can do to assist. You want to look at potentially non-stimulant medications. You want to potentially, for those that you're concerned about abuse potential, you want to screen for those patients who are most likely to abuse substances in the first place based on family history or individual history. You want to look at behavioral interventions potentially in place of, or certainly in addition to, stimulant medications. You want to think about how they're managing their prescriptions, only giving them the 30-day supply, having someone else assist in monitoring the prescriptions, and if they are in a situation such as on a college campus, educating the patient on how to manage that prescription so that somebody else doesn't have access to it.